guess I better introduce you now. Your CV is bloody impressive. 15 years of ODOP. You're the immediate past president of CCLS. You've worked in a couple of flagship practices in Auckland, and now you're starting on your own flagship practice. That's specialist care, right?
Yes. So we are a little bit unusual in that we don't sell frames. We know there are a lot of amazing practices in Auckland that sell really good frames, but we kind of saw and we're seeing a growing demand for services like dry eye, like I know you are. So we wanted to create a dedicated space to be able to actually offer that to the highest level. Same thing with like some of the more unique contact lenses, and just anyone who kind of wants a really high standard of eye care. So just a dedicated space focused on services called Illume.
And it's in Jervis Road, right?
It's at what's called the Three Lamps End of Ponsonby. So it's
Yeah, I might pop my head in there on Friday. I'm going down to Pod Lab, which is at the bottom of the hill. That's JJ and Dom's podcast studio.
Nice.
And then I'll pop up the top of the hill. Yeah, and then I'll go back and pick the girls up from Newmarket before we head over to the store to watch my daughter's ballet, or not ballet recital, dance recital.
Dance recital. And hope they haven't done too much credit card damage in Newmarket in the meantime.
We were just with Gilmore girls, and in that all three generations were shopping with the mum's credit card. Mine doesn't let me have a credit card.
So I'm going to get completely sidetracked. Do let me know about Friday, because I know we're going to talk today about, I guess, dry eye diagnosis and also management, focusing a bit on IPL, but there's some stuff I'd love to show you, which is,
very cool. So what led you down to specialist care? It's an exciting right now, and I think it's us having to learn therapeutics and then go back and get certified in it. Like, when you signed up for optometry, were you thinking glasses, and then as you went through the course, like, wow, this is medical?
I'm unusual in that I had never been to an optometrist before I came on.
Wow.
So it sort of got suggested to me because I knew I was interested in sort of the health sciences sort of space. I knew I was good at things like biology and sciences and things like that. But I also kind of knew I don't like blood. So there was aspects of me going, I know I should be sort of looking at healthcare degrees. So optometry got suggested to me, and it kind of grew on me. And then as I got into optometry, when I started, I loved the fact, and I still love the fact, that it's such a wider profession than most people realize. Okay, on one end we kind of have this fashion and style element where we kind of can really change how people look and how they're perceived, and that's both from a frame styling perspective, and of course the technology and styling around frames is just continues to evolve, and of course, like anything fashion inspired, goes around in circles a little bit as well. But then there's the aspect around contact lenses as well, people being able to change their look. So that side of things, that fashion and aesthetic side of it, always sort of fascinated me. And then getting into it more, just knowing how much you can do as an optometrist. Vision is at our core, but to give patients good vision, they have to have good tear quality, they have to have good eye health. Eye health is so linked to systemic health, to lifestyle, nutrition, all those things. So the way we can influence people's lives with optometry is really wide, and I'm sounding obviously very lofty, and that's probably why I really like what we do, and I'm very always happy to share ideas, and that's probably why I'm bad at saying yes to helping with things, because I think anything that helps with colleagues' education, patient education, patients' access to care, I just think is a positive thing. One of the things you didn't mention is I did do a master's as well, and that was all literally focused in on quality of life and beyond vision correction, basically, in terms of what we do as optometrists. So I just think, what most optometrists can offer the average patient in New Zealand is actually probably a lot wider than the average patient realises.
How did that topic come about?
I know.
I've got this idea around, there's a question from Grant Spoken around fasting, and could it be good for macular degeneration? Could an optometrist prescribe fasting? And that sort of links in with macular degeneration, links in with diabetes, and links in with dry eye. Trying to get
100%.
the gutting things back working. But how do you start posing a question about impact of life? Like it's broad and it's narrow.
It was around the time, and I did this, it was a few years ago now, but it was really, at that point, it was really centered around contact lenses, because the average person thinks of a contact lens being something that gives you an alternate to seeing rather than glasses. But contact lenses, we can change children's lives, right? Whether that is a myopic child and we're doing myopia management, or whether that is a highly hyperopic child. We know there's evidence around impacting children's, not only their vision, but their ongoing eye health and their confidence, their self-esteem, their sporting, their academic performance. We're using contact lenses to heal the epithelium, so that whole therapeutic use of contact lenses, it sort of delved into that as well. Again, for dry eye, for recurrent corneal erosions, all those sort of things. So it was really focused in on that, and a whole lot of sort of patient series around how contact lenses were helping patients beyond just seeing.
I brought up that you'll be immediate past picture of cornea and contact lens.
Yeah.
What do you see those two go so well together? Like obviously you put a contact lens.
Well, cornea and contact lens is, I guess, as a for those who aren't aware, it's an organisation in New Zealand that's been around for, I may get the maths ever so slightly wrong, but 67, 68 years. We're actually one of the oldest organisations who focus in on anterior segment health, really, and it's actually ophthalmology and optometry. So while the vast 90% of the membership is optometrists, there's a good number of anterior segment ophthalmologists in there. I guess the name Cornea and Contact Lens Society doesn't necessarily represent everything we do now. It's an education not-for-profit that's focused on anterior segment health, really, and contact lenses are a big part of that, but so is things like cataract surgery now, so is things like refractive surgery, so it sort of does encompass those things now. The title probably just comes back again from the evolution of those sort of organisations. There's lots of similar organisations worldwide. Australia has a similar group, British Association of Contact Lens Practitioners, BCLA, there's a lot of similar groups around the world who have contact lenses in their title, but they're a bit more evolved than that now, just because of scope of what we can actually do.
Nice, and it's a good conference to go to and sit there and get some midlife therapy and see all the gadgets and which I know you love.
Yeah. So plug for the optometrist, it's an ophthalmologist. It's in Tauranga next year, and on Valentine's or around Valentine's Day. So easy date to remember.
Yeah, I'm trying to figure out how I'm going to come because I've got to go to a wedding on Valentine's Day. So yeah, that's in Palmerston North, which is not too far away, but I don't know about direct flights. Yeah, we'll sort that out. Yeah. So speaking of gadgets, I've just put into our practice a dashboard in IPL. It's something that I thought we'd be able to do right from the outset. But as they say, everything costs more and takes longer than you hoped. And it's been about 4 or 5 years since I've had IPL in practice, and already because I didn't have it, I referred a couple of people up to Christchurch because it just does make the world of difference to some people. The person that was getting the current audiolum, so styes, and all their glands were receding, so falling backwards. That's why they were blocked. They had all this little inflammatory blood vessel along the margin. I got to see them back for their review, and without any heat or anything, I just gently pressed on their eyelid, and all those flares expressed very, very nicely. And I was like, gosh, I've got to get this moving, and luckily we are. And yeah, to have it back and just know what it can do is pretty amazing. When did you first get to use an IPL, Adele?
So first use I couldn't recall. Routinely using, it's probably been at least, actually you start aging things based on the age of your children. It's been, it'll be coming up 10 years that I've been using IPL routinely in practice for dry eye patients. And it's something that, even though you could argue that that's quite a while, surely things have changed. it works. So again, your patient selection, I think, has changed a little bit in terms of how I choose people. All the things you just mentioned are really important. But it's something that the evidence in terms of both the literature and these amazing researchers we have worldwide does continue to stack up. Yes, we sometimes refine protocols and things like that. So even in that time, you'd be aware the treatment protocols slightly changed. We tweak things slightly differently occasionally. But it's something, routinely in practice for 10 years. But the utilization of it, even while I've had other things in, just continues to increase, kind of thing, because it just helps, and I will probably talk about this a little bit more, but it just actually helps target the underlying condition. Whereas so much what we do with dry eye is, yes, cleaning and making sure we have, good lid and lash health on the surface is important. Lubricants help, but IPL helps actually treat that underlying condition and actually help improve function, help reduce inflammation, help with the Demodex count. So it just is so comprehensive in how it's caring for patients and actually improving their eyes.
Yeah, nice. And did you sort of start off quite in case and then sort of suggesting it earlier, or and then some in cases you sort of look at it and you kind of go, I don't know if there's anything left to help. Like one of my classmates was working for an ophthalmologist in Sydney doing serum and things like that, and she was quite, of the opinion that if I can see 2 or 3 glands there, then I'm going to get at least some benefit out of still using IPL.
Yeah. So IPL, I feel the vast majority of patients will benefit them. How it's going to individually benefit them may change in that discussion with that individual patient. So yes, when I'm mentoring any younger ones, kind of if they're new to IPL, if they've got meibomian gland dysfunction, the glands are sort of flowing, but the oil quality is poor, and they've got that lid margin telangiectasia, so that redness along the eyelid, they're the patients you're going to get the sort of the most easy success with, okay? But there's such a spectrum of meibomian gland dysfunction. There's the patients who are really mild with intermittent symptoms. There is patients, as you said, with late stage disease that it's kind of just been grumbling on for so many years. And sometimes they'll have significant degrees of atrophy. With patients, IPL is often one of the core treatments, and there's a range of treatments we have the luxury and benefit of being able to offer, but IPL is definitely the one we utilize the most, or sometimes in combination. If it's a early patient, there's a couple of different ways you sort of present it. So I guess when I'm talking about early versus advanced, this is where I guess for any patients or public listening, this is where really getting somebody to do that clear diagnosis, so you can make educated decisions about what's actually going to help you the best, is really, really important, rather than just getting that blanket statement of dry eye or dry disease, getting some idea of the severity. If it's mild, it's more of a let's get things functioning more normally, let's reduce your dependence on having to do warm compresses that no one really wants to do, having to use drops if they are. It can just sort of help improve, again, their quality of life on a day-to-day basis, because you're being proactive. It's almost like a preventative medicine approach where you're actually let's just get your glands functioning as well as they could. That also is important for some of our contact lens wearers, right? Because there's studies showing that IPL can improve contact lens discomfort, so it might help them just wear their contact lenses better. If I've got someone who's more at the severe end of the spectrum, so whether that be severe meibomian gland dysfunction with significant atrophy, or they might be severe meibomian gland dysfunction with, as well as moderate to severe gland atrophy, so where the glands have just decided you're not using us, so we're just going to shrink. You've got to look at the quality of the meibum, because some people will have atrophy, but the glands are relatively flowing well. But you might have atrophy and just really meibum that no matter what is just not going to come out. So for those sort of patients, their symptoms are often more severe, their presenting signs are obviously more severe, and they're the ones that, look, it's taken you a long time to get to this point, so it's going to take us a little while to unravel this. So there's sort of 2 ways to look at it. One is, we need to do all we can to stop you getting worse, but also improve where you're at. But we kind of expect they may still have to continue significant home therapy. They may still need closer top-up treatment. So I've got lots of patients who now just come in for their single annual 1 top-up treatment. That's all they need, and that just maintains things. I've got other patients who need quite close maintenance treatments to keep them comfortable and functioning. So it's just It has a place in most dry cases. It just depends how it's going to suit that patient and how it's actually going to probably benefit them. Because what you don't want to do is, I mean, if you just quote a study and say, look, because the studies say 86 to 90% of patients get really good results. And if you promise that to every patient because you haven't done a really good diagnosis, that, you know, you're going to have some unhappy patients, which I don't like. Obviously, sometimes you don't get the results you want, but it's definitely rarer nowadays. That's probably the change over the 10 years. Is when I was starting, some of that analysis that we were doing, some of those diagnostic protocols that things like JEWS 2 and 3 have given us, maybe weren't so clear. So maybe you were just using a little bit more blanket, whereas now it's definitely a little bit more targeted, a little bit more considered in terms of what I might add to the treatment. And also, and you've got me on a real tangent, sometimes what I'll do before the patient has treatment. So we might want to say, look, I think IPL is going to be a really good option for you, but they may be in such a sort of a flare up of their symptoms that we want to quieten that down. Some patients, that's with topical steroids and oral azithromycin to start with, you know, 2 to 4 weeks prior. Some patients, we do it with Optimal. Let's dampen down that surface inflammation before we do IPL.
That's Manuka honey drop.
Yes.
Sticky gel, isn't it?
Yeah. So Optimal is a Manuka honey is a key active ingredient in it. It's obviously got a longer, fancier name than that. That starts with L, but I can't remember. And how I describe Manuka honey to patients is basically, there's some really good, or Optimal patients, there's some really good studies showing that it's going to improve symptoms, it's going to improve redness, it improves kind of the local microbiome in the area, it improves blepharitis, and it can improve myelin quality, because there is studies on this. The only disadvantage is that it's going to sting when it goes in. And most patients don't mind that it stings, and this is true, this is based on patient feedback. Most don't mind it stings because they know it's gone into their eye. And after 2 or 3 weeks, they find that actually it's making my eyes feel better. It's helping reduce their need for other drops sometimes, and it does. It just sets them up for success a little bit more. Yes, there's some patients who can't tolerate it, but it sometimes can be a bit of a game changer for a lot of patients as well. Yeah. And I guess this is, you're going to find a theme, sorry, and you're like, stop talking, is because dry eye disease and meibomian gland dysfunction, and even to extreme extent things like Sjogren's syndrome and things like that, they are multifactorial conditions. The reason an individual has eyes that feel the way they do or look the way they do is from a multiple of reasons, and it's different for every individual. So, but you've got to come at your treatment with a multifactorial approach. I think you don't want to throw too much at people, because otherwise then you don't know what's helping. That's my other thing, is it's a happy medium of finding what's making a difference for that patient, but also what's not bombarding them with too many options. And this is where, again, some patients want to do all they can in clinic so that they don't have to do too much at home, and that again is a place where IPL sits really, really well. Yeah,
I think what I'll describe here is these meibomian glands are like specialized sweat glands, and they produce
sebaceous glands,
and they can, ideally, they're nice and sort of almost clear, the consistency of olive oil. Then it gets to sort of being a bit yellow, and then what we describe as granular, so sort of chunky bits within it, like if you put your olive oil in the fridge, I guess. And it goes quite buttery and quite toothpastey. And then, like you say, these glands aren't moving anymore, so they shorten and in some cases drop out. Often that's why somebody might have an ingrown eyelashes, because that gland has dropped out and it's left a little notch in their lid margin. And I put up a post yesterday about how roughly 80% of dry eye is caused by meibomian gland dysfunction, and rightly in Australia.
I think I could tell you the references. Lemp, I think, it's the Lemp study that showed 86% is meibomian gland dysfunction. And it's that cycle, right, where even patients who have aqueous deficient dry eye disease, give them long enough, if it's unmanaged, because of friction and that inflammatory sort of cascades that happen, they'll end up with meibomian gland dysfunctions. This is why it is so important. Yeah,
and he rightly said, it's like David, he's from Cornea, Australia. 80% question mark, and he's like, well, we've got to be careful not to just say just the gland is the problem. And I completely agree. Like as you said, the awareness, and I spoke about there with fasting is just one tool for gut health, but it's like what's your fibrous vegetable content like? What's your omega-3s like? What's your inflammation like? You just said there, like with low tear volume. I've had a few lately with what's called lid wiper epitheliopathy. So it's basically your eyelid rasping itself on your eye and inflamed and sore and rubbing. That can escalate to the conjunctiva and the cornea becoming inflamed and damaged, and then, as you say, you end up having this bombarding conversation of, right, this is where we're going, this is where we need to start.
Yeah, and there's a woman who runs a dry eye clinic in Adelaide who I know she did a post a few weeks ago, and it just resonated so strongly around dry disease. It's really common, but it is, while we can simplify things, you do have to have a few different options. Whether it's like why you can't just stock one lubricating drop, because some patients need different ingredients, some patients need different percentages of active ingredients. You've got to really have a bit of a refined approach. And so this is why, I know you're doing punctal plugs. I know you've got lots of options in terms of lid and lash cleansers and things like that. One thing we haven't touched on is actually the IPL you've got has a protocol now for chalazion management as well. And so you can actually use it as a targeted therapy. So for those, I guess, to not use the word chalazion, those lumps that form after you've had a sty, you can sometimes get those little hard lumps in your eyelid, which are just annoying, unsightly, can blur your vision. But you can actually use IPL as a localized treatment and there's some case series and things now showing reduction in chalazion, not having to do things like lancing and surgical techniques and things like that. So you're actually improving the underlying gland integrity as well. So there's evolving scope with the IPL as well.
Have you had a go with those shells and you've used some liquid?
Yeah, we've had a few patients this year that we've been doing it with, and there's kind of a couple approaches, and it depends on the patient. Some patients will have been treating their meibomian gland dysfunction and we're pretty happy with that, or they literally have pretty good looking glands, but for whatever reason they've just got a really big chalazion. So that's where just a localized treatment works quite well. You do them weekly over about 4 weeks, and it just helps break them up more quickly. There's the odd patient who they've got bad, by the time they've got to us, they've already got bad meibomian gland dysfunction and they're just sick of all the lumps in their eyelids. We've had a few ophthalmologists as well who are sort of going, actually, we could lance it and cut it out, or we could send you these guys to actually treat it non-surgically, which is going to, again, lead to better eye health in the long run, right? Because their gland integrity is improving and we're not losing glands, damaging glands. Yeah. So there's a few different things you can do. And I can, as I said, if you pop in on Friday, I can probably show you.
Yeah. So you do a lot of coaching and breath work when you're putting in that guard for the eye.
I guess it's like a lot of things we do in practice, right? You like anything, you choose your patients in terms of what you're recommending. I think you get a sense in a general eye exam how comfortable people are with you around their eyes, right? You kind of sense the patients who you're like, I'm not even going to suggest contact lenses because I can't even hold their eyelids up or down. So for most patients, no, it's like a gonio lens. It's like, when we're checking anterior chamber angles, it's like, we do things like lipoflow and stuff as well. So they are, you're closing up people's eyes kind of thing. Even I use actually now more often, rather than the little goggles, I use little adhesive IPL covers. And so even those, right, I had a patient comment honestly yesterday going, I'm fully trusted now because you've closed the person's eyes completely off and you're just in the, you get it's one of those things like anything. If it's not working for the patient, I'm not going to put it in there. I'm not going to force, like you do what works for that individual patient. Yeah. But they're just like a contact lens, really.
Yeah, I've got a little 3-year-old who's just got lasers both sides, and it would be great. And I can really look at her eyes. I'm thinking, this would be a great answer, but I don't know how we could do this.
Yeah.
Yeah. Talk to me about lipid flow. Again, that's quite exciting. A little session of having your eyelids pulsed with some more.
So lipid flow, I mean, again, is a really established treatment, right? If we think IPL's got a good 15 years of literature and evidence, at least, on it, lipid flow is sort of similar. It's probably, again, a 12-ish year old technology, and it's kind of, I guess, still considered the gold standard in terms of expression of the glands. And reason being is it's a 12-minute treatment at the right temperature at constant movement, basically. And I have had it done myself because, again, most things I will, pretty much everything, I will always have it done myself to get a sense of what's the patient going to experience, how does this feel, how do I sort of describe it. And it's actually for everyone, it's more comfortable than manual expression. So, of course, we've got a really good body of evidence showing IPL alone works, but we also know there's studies showing that if we combine IPL with manual expression, so again, using our special little forceps to massage the glands to encourage the oil out, that's going to also help the patient. And the most effective way to do that is with lipid flow. The only downside of lipid flow is it's single use, that these little microchipped, individually sterilized activators. So it's a bit of high-tech stuff that we use once on that patient. So the cost is it's one of the more costly treatments. But some people love it, and some people again find it really easy.
With drops, we've touched on it. We've got Luke Hardy, we've got Novartis, try to mount things. We've got these various types of lubrications which do different things to the surface of the eye, and there's oils, and then there's Demodex. With your product that you're also part of the Island Eyes, I put on yesterday and today. It's quite good actually. Is it just full on face serum?
I do, yeah. It's funny because I go through phases where, like, if women know what I mean, like an oil, sometimes you just want to do an oil cleanse of your skin in general because it's really soothing. So I do use it full face quite often just to, and then do a warm face cloth to sort of wipe it all off afterwards. Yeah, it's good at removing makeup and stuff. Demodex is interesting, right? Demodex is, I think you've done a couple of posts on it before. It's these, to some extent, some level of Demodex is normal, right? So as much as telling people that there's these little mites that live in our sebaceous glands in our skin, and particularly on our eyelashes, sounds horrific. It's, to some extent, we're allowed a few of them. It's kind of like our normal microbiome a little bit. But if, like anything, if too much is not good. So if there's too many of them, that's when we get, more irritation, more bacteria in the area, more discomfort, more meibomian gland dysfunction, lash loss, and things like that. Demodex often needs because it's a mite and it's breeding, it does require a little bit of couple of different approaches, right? You can either try and be really good with your home management with cleansers and things like that. And that was why, one of the reasons why, obviously, I was trying to make a New Zealand range of lid and lash cleansers. But also, IPL is going to help it. So IPL kills Demodex as well. So if you've got patients who, or if someone's got it, they just can't get it under control, IPL is going to help break that cycle of, that life cycle of the Demodex mite, because they've got pigmented bodies, the light absorbs into them and it kills them. So that's another real key advantage of IPL. Demodex, I approach, as I said, home maintenance really important, but in practice treatments are important as well. And there's two key ones I do. One is IPL. The other is actually the Zocular Zest cleansing system. So that's actually an in-practice cleanse that you can do for your patients. It's designed by an ophthalmologist out of the US. So in a similar vein to, I guess, why I created Elan Eyes, we know tea tree oil can be really effective for a lot of things, including Demodex, but we also know that some people just do not get on with tea tree oil. It can be really harsh. Some people can have allergies to it. There's emerging evidence around it may have some negative effects to meibomian gland health. Yes, a lot of those studies were in vivo, so we need more research in the space around that long-term impact of tea tree oil. But some people just don't get on with tea tree oil products. If we don't have to use tea tree oil, let's not. So hence, some of the things in, I guess, Elon eyes is around, castor oil and things that have shown activity against Demodex. And then in the Zocular range, he uses an ochre complex. So from another, again, a plant-based product, and that's really effective. And you do an in-practice cleanse. You do them spaced apart, so again you're breaking that cycle. So if you're just worried about anterior blepharitis and Demodex, I would do that over potentially IPL. But if they've got everything, you can combine. Yeah, you can sort of combine a few things, and that's an easy one to add to the practice as well.
Yeah, and it'll be interesting where we end up going anywhere with these ivermectin derivatives. Yeah.
Yes, there is a dry eye clinic in Wellington who does use them quite a bit and is absolutely loves them and thinks they work really, really well for their patients with Demodex and significant meibomian gland dysfunction. Challenge is accessibility. It is off-label use, and it is what we call Section 29 prescribing. So it's a little bit harder and not as accessible for patients.
It's a wonderful world.
Oh, no, it is though, because for better or worse, there's so much innovation, right? And innovation that's focused on helping people, like have healthier eyes, healthy, comfortable eyes makes people feel better, makes their vision clearer. So again, we do, by treating and managing dry eye disease properly, we're not only treating their dry eye disease, we're helping with their vision clarity, we're helping with their work productivity, we're helping with their contact lens comfort, we're helping with their mood, and there's a few studies showing links to depression and anxiety and things like that, and possibly a chicken and egg situation, possibly sometimes there's medication links and things like that, but there's no doubt that improving dry eye disease helps with patients' quality of life, and so that's a good thing.
Yeah, I know when you're doing some of these questionnaires, it's talking about frequency and impact. And when people sit there and think about it and how much of every day is taken up with dealing with this condition, it goes out from, I know the speed's out of 28 and sometimes you're scoring in the high 20s. Goodness, this is happening every single day and getting in the road of everything you're doing. And when I say productivity, you're on a computer, you're not blinking so much, it's burning, it's disrupting, you've got to find your drops in the end.
And the other thing I find, the symptom scores, I know the symptom scores are, patients can kind of go, what is this question? But they're relatively, a lot of them are quite highly validated. And it's often about just, let's shift your number, because sometimes we all have good and bad days on a lot of aspects of our lives, and dry eye is the same. Sometimes you wake up and you go, oh, my eyes are bothering me from the get-go. Other days, they just won't bother you at all. And so I guess for me, managing dry eye, it's about reducing flare-ups. It's reducing that symptom score so that you have more good time than bad time. And so that's the other thing. I think it's important to continue to do those symptom scores at the checkups, because then sometimes you might come in and go, I don't think it did anything. But when you reflect and actually did symptom scores, you go, oh, shoot, you've dropped from a severe into a medium, moderate sort of thing. So they're really helpful, I think, and important.
Yeah, and even like non-invasive tear breakup. Our patient today, we've done it last year when we first saw them. And like I said, the little and often at-home care had made a difference to them. One, it's still bad, but their other eye was almost back to relatively normal eye. It looked like the non-invasive sort of, we're getting a little bit of breakup around the outside, but the main body of the tear layer was good. And I was like, that's quite cool. All your hard work. I know your other eye's not. All your hard work has actually done something.
And again, we know that warm compressors, when done correctly, do work. Of course, it does come down to how are they done correctly. So not doing them for better or worse with warm. The only place I see for a warm, wet face cloth is if you're actually trying to get rid of anterior blepharitis. I think a warm, wet face cloth in that case, because you're going to loosen everything. But otherwise, of course, we know the studies, and a lot of them done locally, show that you do need, that at least 10 minutes, 42 degrees, that's, sustained heat. So doing them properly, and we know it works, but it's often, 10 minutes once or twice a day, every day, can be 100% burdensome for people. And I know I'm guilty of it as well. I should do them every day. I do them when I remember,
Yeah, I think you're explaining, like, okay, so You want to use the face mask, right? You're going to roll it up tight. You're going to run the tap as hot as it can be. Yeah. Put it under, squeeze it. 20 seconds later, put it under, squeeze it. Do that for, like, say, 10 minutes. And then they kind of go, oh, and then you put the heated up face mask on for 10 minutes. Going, this is a lot easier.
This is so much easier. Yeah. I had someone recently who I sort of gave them a whole lot of options, and they took the micro version. And then about 5 minutes later, she came back and she goes, no, you're right. My husband said I'm going to jump into bed and forgotten to have done it. So if I've got one that I've just plugged in next to the bed, it is easier. So yeah, the electronic ones have been a bit of a game changer, I think, in terms of making it easier for a lot of people.
Yeah, that is another revolution, isn't it? People warm it up, sit beside the bed, and off you go.
Because even when I studied, I'm just trying to think, there probably would have been brooder masks, but that would have been the only thing, right? And they probably were quite expensive. So it was.
How was it? You know, the original. It's got like a little pin plug.
Yeah.
Yeah, you put those little rings in there that you soaked and warmed up.
Oh, the Bleefstein goggles.
Yeah.
Yeah, so those have gone obviously through a few evolutions. They used to be obviously really easy to get in New Zealand and Australia, but they were deregistered as a medical device probably close to 15 years ago. So the ones that are either, are sort of floating around are either old one. We have one and we use it. We have some patients who still love it. So we're just like, okay, cool, but there's all these other options. And there is a new one that came out, but you have to import it from Ireland. And it goes out of stock occasionally and things like that. So just the plug-in ones are just so much easier.
What was the concern of Bethany? That's them heating up water.
Really, because it's you sterilize them and things like that. It works for a lot of people and it's good. It was honestly something to do with medical registration stuff, in terms of if you're going to bring a medical device into Australia and New Zealand, more so Australia, and for better or worse, we get tacked on in some cases with stuff. Someone has to sponsor the medical registration as a device, and that's obviously very expensive and things like that. And then and then from what because I've every so often I'll contact the manufacturers and go, look, is there anyone looking at bringing, because a lot of patients loved them and did buy them and had them at home, but now you'll find that some practice, and again, we have an old one, and some practices have the newer model as well, but I just think if we go back to what I was saying earlier, if all we're doing is warming and then trying to encourage the oil out, yes, that helps, but it's not helping the underlying condition. IPL helps the underlying condition because you're actually helping nerve flow, you're helping nerve stimulation, you're doing photobiomodulation, you're helping blood vessels, you're getting rid of Demodex. So it helps the underlying condition. Same thing with obviously things like omega-3s and things like that. Whereas, so that's why there was definitely a phase where lots of people, the only service they were offering patients was, let's do an in-practice warm compress and expression. And I think we've definitely gone beyond that now. We should be trying to do more for patients, because that's just, it helps, but we could be helping more.
Yeah. Awesome, Adele. Is there anything else you can think of for a discussion on where we're at with dry aloe these days?
No, I think it's very exciting that you've got more than a few tools in your belt now in terms of helping patients in your region with being more comprehensive and being able to help them, and again, somewhere where it's easy and accessible for them to get to. I think it's more just people understanding that unfortunately, it is a chronic condition, and you do sometimes just have to find, well, what's the recipe of in-practice treatments and home care that's going to help me. Some people use, and again, there's really good studies showing regular lubricant use with the right lubricant can help. But other people, it might just be around doing lip hygiene and in-practice treatments, or warm compresses and in-practice treatments, diet, all those sort of things can make a difference as well. So I think it's just people understanding that it is multifactorial. You want to go to someone who's going to give you a really clear diagnosis, like fine. But there is a lot of options that can really help people. I had someone recently, and this is, going and starting up a new practice recently, you have those moments where you're going, God, what am I doing? And then you have patients who go, no, this is why I've done it, who had been seeing another clinic for a while, came in, did just her workup and sort of talked her through all her options. And she said, when she came in for her first IPL treatment, she sort of said, when I saw you, I jumped in the car and started crying. And of course, the first thing you go, oh, you know? And she said, because I finally realized I actually have options and I don't have to just live like this and put up with this, because she was having to do warm compresses 4 times a day just to get comfortable, so wasn't wanting to go on work trips because she couldn't do warm compresses that often during a work trip. And so it is, people don't have to put up with discomfort, so don't like, just, you know, actually there is things that can be done. And it's not just about eyes feeling and not looking as red. It's about keeping your vision clear, keeping, you know, the eye surface healthy for longer. Leaves you better set up if you want to have laser surgery. It'll leave you with healthier eyes pre-cataract surgery. There's just, dry management just helps people in so many ways. I'm obviously overly into it.
Good, that's good. Thanks so much, Adele. I'll stop with Facebook Live, and I'll stop this recording.
Thanks for the chat.
Yeah. Cheers.